And our first speaker is going to be Dr. Andrea Meyer. She's our board certified dermatologist. I'm going to ask you to hold all of your questions until the end of her talk. And then she and I are trying to maintain the social distancing here this morning. So when she's done with her presentation, I'll come over here and we'll bring up the questions for her. So with that, I'm going to go ahead and turn it over to her.
Hey everyone, it's good to be around people again, even if it is digitally. So as far as today goes, I want to talk about immune-mediated skin disease. So a couple things. One is I'm expecting. So I have my water and my protein shake here to keep me not from passing out. So I apologize if you see me taking sips here and there. So we have 2 baby boys coming in this July timeframe. So just as an FYI, that's kind of why I'm taking my protein. So as far as immune-mediated skin disease, it's a really broad topic. I could talk about that for pretty much an entire day. So I did narrow it down a little bit. These are the kind of the different disease processes I'm going to talk about. The first thing I want to talk about, obviously, is biopsying. I mean, a lot of what we're going to do with diagnosing an immune-mediated skin disease is going to be a biopsy. Not in every case, but most of them we're going to do a biopsy. And it does matter a little bit on how and what we take for samples. And so I know a lot of you guys do this all the time. I know it's probably a little secondhand nature, but I wanted to kind of go over my specific technique and see if there's any kind of tweaks that you guys can do if it helps you guys at all. So, and then we're going to talk about some skin, obviously specific diseases. Again, it's not all encompassing because obviously there's no perineal fistulas I'm not going to really talk about those a whole lot because I feel like a lot of people have a decent grasp on that. If you don't feel that way when we talk about questions, bring it up in a question and we can talk about that too. Same with sebaceous adenitis and the standard poodle, Akita, Visla. But in general, these are kind of the diseases that I see, and some of them are overdiagnosed, I feel like. It's like Pemphigus vulgaris, like people are like, oh, it's PV. I'm like, well, probably not. I'm getting a microphone. Hold on 1 second. Hopefully I don't kill your ears. Is that better? Can you guys hear me? All right. So when you're taking a biopsy, the biggest thing you're going to do is make sure that you pick the right sample. Because if you have a sample that's not diagnostic, then you went through the entire process, the owner paid for the money, the dog went through the procedure, and you have a biopsy sample, that's not actually going to give you a diagnosis. There's still a chance that you're not going to get a diagnosis of the biopsy. I always warn owners that there's always a possibility that we can go through all of the hoops, we can go through all of the samples, and still end up in the same spot. But you can still interpret what you see on your biopsy in light of treatment. So say it just says inflammatory skin disease. Well, that gives me a lot of information. So picking your sample so you get that inflammatory skin disease is important. So when I choose one, this is kind of the order I choose. First, I want that pustule. If you're a recent grad from the U of M, you know Dr. Shayla Torres has the beautiful, beautiful pustule. That's going to be your ideal sample. They rupture really easily, so you have to be really careful and you have to make sure that your biopsy punch is bigger than the actual pustule itself. So if you have a diagonal lesion, we have really big lesions, you're probably not going to get a great sample from the pustule. You're going to want something that's a little bit smaller. Then comes the papule. So obviously it doesn't have the actual purulent material in there, but can still be very diagnostic. Then I'll do the crust, and you want the actual crust part of your sample. So that's going to be, so if you have like an epidermal collarette type of lesion, you're going to want to get that periphery. You're not going to want to get the center. Erythema, so if you just, all you have is redness, like we'll sometimes see in a condition called Wells syndrome, you'll want to get the redness area in the center, not again the periphery. The only time you really want a peripheral lesion is if you have a true ulcer. Whereas all you have is ulcers or erosions, you don't want the center because all you're going to get is a defect in the skin. And the pathologist is going to say, hey, you have a big crater. Yep, you do. So then you're going to want to get that periphery. And that's going to be for your really severe skin diseases like your Pemphigus vulgaris, your bullous pemphigoid, all those kind of more zebras that we learn about that we don't really see a whole lot. but those are going to be ones where you're going to get the peripheral. And sometimes the pathologist can recommend special staining for those, like immunohistochemistry or even salt split staining. Those are really kind of specific, and they usually give you a recommendation if they're going to recommend it, especially if you're going to do a dermatohistopathologist. One thing I want to stress is don't get normal skin. So if you are suspecting like a follicular dysplasia, something like that, and you really like, I just want normal skin to make sure you can compare, take 2 samples. Take a normal skin sample, take an affected alopecia skin sample, but don't do it where like you have the lesion and half of the top is like normal and half the bottom is lesional, because if they cut through when they're doing their sections and you only get the normal skin, they're going to come back as, hey, normal skin, and you might not have to, you might actually get your lesion. So I avoid getting normal skin. And usually most pathologists want a 6mm punch or bigger. Sometimes you can get away with a 4 if you really have like a nose lesion or a tail lesion or ear lesion. If you want to make your pathologist happy, probably try to go for a 6. And again, no central erosions or ulcerations for that same reason. You're just not going to get an answer. You're just going to get a huge crater, and that's not really helpful. It's just going to be inflammatory. Don't clip and clean. I've actually worked with some surgeons. This was actually during my residency where we had this big lesion and I didn't feel comfortable taking it. I wanted to take the whole lesion because it was a therapy dog. And we had this huge argument. She's actually one of my best friends. And we had a pretty heated argument because I'm like, you can't clip and clean. And she's like, I can't do surgery without clipping and cleaning. So what we actually ended up doing is she could clip the outside of a lesion and she kept my lesion inside clean or non-clipped and clean, and we got a diagnosis that way. But don't clip and clean because that's your lesion, that's your crust, that's your pustule. So just they don't get infected. They really don't. Sometimes you need sedation. Usually sedation I'll pick for the cases that are kind of cray, you know, the ones that are like the vet's scary place. Also for those cases that you're going to do a nose, you're going to do a tail tip, you're going to do an ear tip, you're going to do a foot, oh gosh, feet. You're going to want to sedate them. I don't usually need general anesthesia for some of these, but if you feel like you do, feel free. I feel like Dexmed-Torb works pretty well. And I just get the IV, give them some time, and then I'll lidocaine them and kind of go from there. So just enough to kind of cut the edge, not to be scary. Might go a little bit higher if I feel like I need to. Cats, I like alfaxalone for cats because again, sedation. And I just want to try to get them a little bit calmer, but I'll always add something with it so they don't get the twitches because it's really fun to biopsy a moving target. I outline it. I give, when I do my samples, when I'm preparing a sample, I'll do 4 dots around my sample. The reason I do that is so that when I lidocaine it, I know where I took my sample. I don't want to have to come back and be like, okay, so I lidocained 3 samples, which one did I do? Take the wrong one, and then also the dog's feeling it. And that's like one of my biggest fears is I take a sample and a dog feels it. And that's just an awful feeling. And so I make sure I get my lidocaine pretty well in there, and I make sure I know which samples and where I lidocained. I go from the top and the bottom and I kind of fan out. So I'll do like a redirection about 3 or 4 times. I don't particularly pull back on every single redirection. I kind of do it the first time, just make sure I'm not having a really vascular area. You can usually tell if your sample is going to bleed a lot just by your lidocaine. If you start to ooze, you know it's going to bleed a lot. You just kind of prepare for that. Most patients are big enough, that's not a big deal. I usually about 1/2 ml lidocaine per location per dog. That's dog, not cat. Cats get a lot less, if any. But that's kind of usually my standard. I usually pull up 2 to 3 mils per animal. It's a little animal, they get less. Wait 5 minutes. Wait 5 minutes. Lidocaine hurts going in, and if you're not waiting, then there's really no point in doing it at all. So I've had plenty of, it's a kind of a brutal 5 minutes, even though like it should be, it's only 5 minutes, but just be patient. When I take my biopsy, I rotate in the same direction. I've had other surgeons help me again. I'm very friendly with surgeons, and they'll rotate back and forth. That'll give you a shearing force in your sample. And so if I go clockwise, if you want to go counterclockwise, I don't think it matters. Just do what's comfortable for you, but just pick one. I do clockwise. And so I just keep rotating it, and you'll feel kind of like a punch for most areas. Really thickened areas, such as your paw pads, your noses, you're not going to feel that. You'll just kind of be able to pull it up. One thing that I like to do is use a 25 gauge needle to kind of pull up your sample. So when you have it, you remove your biopsy punch. You've already picked away your blood. Sorry, pregnancy. I'll use a small 25 gauge needle, lift up my sample so that you're not using like a forceps. Because if you're really not really, you have to be really gentle with that, because you can really shear and really crush your sample, especially on like glabrous area, like your belly. So I'll use a 25 gauge needle, get down into sub-Q as much as possible. And then I use a curved iris scissors. I love them because they're really, really thin, they're really small, and they cut pretty well. And I'll get really deep into the sub-Q as much as possible, pull it all the way up. Then I bought my sample because you don't want to have the pathologist complain that you have a lot of hemodilution on there. Obviously put it in formalin. Then I'll put some pressure while I'm blotting and doing that. I'll have my assistant put some pressure on the sample site. I do a really tight cruciate. So this is not a surgeon's cruciate. This is a dermatologist's cruciate. I don't have another holding layer. This is my holding layer. And so I'll put a really tight cruciate, pretty much almost as tight as I can get. And then I close them with monocryl so that they don't have to get being that tight. I don't want to take them out. So it'll just absorbable. I submit mine to the University of Pennsylvania. Dr. Malden is double boarded, so she's a dermatologist and a pathologist. They also have Charles Bradley, that's pretty darn good too. So that's where I submit mine. You can get their recommendation for how to submit and all of their submission forms online. So it's really not hard. It's not that much more expensive, but if you like IDEX, they do fine. You just might have to ask for a dermatohistopathologist. It doesn't go there automatically. I'm just picky because, you know, that's what we are as dermatologists. All right, now let's start talking about diseases. If you have any questions about biopsies, we'll come back to those, I promise. So Pemphigus is actually pretty common. I'm sure most of you have probably seen a case at some point in your careers, whether it be which form, doesn't matter. They're all relatively similar. They're just more severe and some are less severe. So it is an IgG-mediated disease. So you're having antibodies attack the desmosomes. Your desmosomes are what keeps all of your cells together. They communicate between cells and they also hold everything together. So that's what makes your brick wall. I kind of call it like your mortar of your brick wall. So if your epidermis is your wall, your keratinocytes are your bricks, your desmosomes are part of that mortar that's going to keep everything together. So when your desmosomes are destroyed, that's what causes acantholysis. So that's where you get the kind of ballooning up, fried egg appearance to your acantholytic cells because they're losing those adhesions. The depth of the lesion determines what kind of pemphigus you have and also the severity. So pemphigus foliaceus, as we'll talk about, is more of a superficial disease, and that's because of what's being targeted is more of a superficial desmosome component. Whereas pemphigus vulgaris is a deep disease, and desmoglein 1 is what's being affected there. 3. So as far as this slide goes, it's not super busy, but it kind of explains why you have different depths of different diseases. So on the right side of the screen, pemphigus vulgaris obviously is a more severe disease process. It's because it attacks desmoglein 3. Desmoglein 3 is present in the deeper parts of the skin, more closer to the hemidesmosomes, which are by the basement membrane. Those are deep, 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 deep. And they're also more common in mucous membranes. So those are really, really important in your mucous membranes. That's why you get periocular, oral, mucous membrane type lesions with pemphigus vulgaris. And that's why you're so sick, is because there's such a deep lesion. Whereas pemphigus foliaceus, which is what we see the most of, it's actually a relatively superficial disease. It's more of a crusting disease. You do have erosions, but they're not all the way thick through. And that's because it's affecting, in dogs, desmocollin 1. And in humans, it's usually desmoglein 1, and very rarely it's dogs. It's a desmoglein 1. But super superficial. And those are present throughout the entire epidermis, not just mucous membranes. That's why you're going to see more generalized disease with this, because you're having superficial lesions and where they're located throughout the body and where they're higher concentrations. Excuse me. So with foliaceus, which is the one that you're going to see the most of, and most people probably have had a case like I mentioned, usually it's acute onset. Most cases don't have a really slow progression. It's usually you have a lot of lesions. The dogs kind of feel usually kind of crummy, but not always, but they progress. So they often start on the face and the feet. So it could be even that they're showing lameness, and then all of a sudden you're getting facial lesions, and then you're getting generalized lesions. It doesn't have to be that way, but that's just kind of the generalization. They're not usually all that sick. Like they're not hospitalized sick, but they can be. I have seen cases where we have hospitalized them for Pemphigus foliaceus when they have really severe acute onset. And those cases have gotten really severe, strong medications like IVIG. But that's kind of the exception, not the rule. If you have one of those, I would talk to the owner about referral just because they usually do need supportive 24-hour care. Not uncommon to see a lot of neutrophilia with these guys. A lot of immune-mediated diseases will have that, so it's not uncommon for me to see 15,000 total white blood cell count to 20,000. As long as that's the only thing, I'm not that worried about it. It just means I need to better control their disease process, but it's not something where I'm like, oh my gosh, I have cancer. So just kind of look at that. And it's usually mature neutrophilia. It's not like a leukemia type situation. They can be secondary drugs, so do a really good drug history. Back in the day when Promeris used to be a product, it used to be associated with that, with topical drugs, and you could actually see it dripping down. Like you'd have like a topical spot where you'd have the lesions, and then it kind of drop down. We don't really have that much anymore because it's not around as much. Amatraz isn't, but I still see it with carprofen and cephalexin and kind of your normal drugs that you're like, they probably did cause a drug reaction. We'll still see it. Dogs and cats do things a little bit differently, but a little bit the same too. So I kind of separated them for this disease process. Dogs have a tendency to get paw pad crusting, so you'll actually have like a yellow tan crust on the actual paw pad itself. Cats have a tendency, you can get paw pad crusting, but usually they get paronychia, where you actually have the nail fold. We'll have like a either green or yellow tan discharge at the nail fold itself. I've had cats, but that's the only clinical sign at all. We've done cultures, and they have bacteria because it's a warm, moist environment, but it's not as big of a deal as like the actual lesion. They're inflammatory. These are panfollicular pustules. So they look like a pyoderma, but they're not around the hair follicle. They're not hair follicle centric. Whereas if you think of pyoderma, that's a folliculitis, that's around a hair follicle. So it's one way to potentially get your brain thinking, this might be more than just a simple pyoderma, but still they can be very, very, very similar. So I'll show you a couple pictures. Both cases usually have a yellow tan crust. It can be hemorrhagic too, especially in cats. Cats have a tendency to be a little bit more moist than dogs, but you'll sometimes have a dried crust and you'll lift it up and you'll have this like really moist lesion underneath and erosion. They should be superficial. They should be pretty red because there's this inflammatory process. I have seen occasional cats with a miliary reaction pattern. I wouldn't say that it would be my first thought process on a cat with miliary dermatitis. It would actually probably be my last, if that's the only lesion. But if they have other lesions like paronychia or lesions around their head, and I'm like, it's probably related, it probably is related. So I wouldn't cross it off and say it's something else. Miliary dermatitis honestly is just a reaction pattern in a cat. It's just cats do cat things. Cats don't really get pustules for anything, but they can, but it's just not as common. These guys can be pruritic, especially if you do cytology and you see eosinophils. Eosinophilic Pemphigus foliaceus is a lot more pruritic than non. So that's just one thing is I wouldn't say that just because the textbooks don't say that they're not itchy, doesn't mean that every case is not itchy. I've definitely seen miserable pupper dogs and some cats with Pemphigus. So distribution, usually this is an additional onset, not necessarily the generalized. So dogs have a tendency to generalize. Cats have a tendency to potentially generalize, but can stay localized. I have seen cats who had only 1 or 2 nails affected as paronychia, and they never went off to develop new lesions. So we still have to treat them, and it's a little harder to diagnose because it's hard to biopsy a nail bed. So usually we'll do symptomatic for them. Cats like their head around their ears. They have a lot of lesions there. Dogs can do the same thing. So it's just kind of there. This is a Cocker Spaniel that has Pemphigus foliaceus. You'll see Actually, I'm going to give a quick kind of, if you guys have kids watching at home, this is probably the least offensive of the pictures, so they will get worse. So just as a FYI, if you have anybody that has a sensitive kind of predisposition, just let them know, because as a dermatologist, I like pictures. So I've got lots of pictures. So just want to heads up, I should have told you that already. Sorry. But I know most people are at home right now watching. So if you've got kids around, or husbands or wives that aren't used to seeing graphic pictures of skin disease, now might be the time to step away. So this is a Cocker Spaniel. You can see the yellow tan crusting around the ear. You can also see the superficial margins or erosions are not really, really deep. But again, that classic distribution of around the ears, head, around the eyes, kind of the muzzle too. Paw pads. So more classic is gonna be the left. You know, they're not that severe. You can see the kind of upper paw pad has a little bit more crusting, but it's still not normal. Excuse me. Versus the one on the right is definitely more severe, and that is Pemphigus. I would also have on my differential, if it wasn't a super healthy dog, considering hepatic-cutaneous syndrome with that dog on the right. This one's not, obviously, but that is also what hepatic-cutaneous can look like. So just as my FYI. You probably won't see a lot of hepatic-cutaneous syndromes. If you do, I'm sorry, because they're not fun cases. I've had usually get them in runs. I haven't had any lately, which is great. But that can look like that. But see how this could, if you had a milder case, look like a pyoderma. So you've got these pustules, you've got the epidermal collarettes that are kind of collarettes, and then you've got just erythema. So if I were to biopsy this, I would take, I'd take one of these lesions here. I think that'd be a great pustule to take, and you can get definitely around it. I would take right here. So see how that's kind of the crusting is on the outside. I would not go in the center because that's already healing. See how it's hyperpigmented? You don't want that. You want this. And I would not avoid up, I would avoid up here. Because you don't want the hyperpigmentation. Again, that's just healing. That's a reaction pattern. But you could do the erythema too if that's all you had. Well, you've got lots of other options. I wouldn't just do the erythema. I would pick these nice pustules. I had my choice. Another severe case. This is obviously a bulldog with generalized Pemphigus foliaceus. I have one that's a little milder, that has very similar lesions. She actually has hair still. And she also has a lot more facial lesions though. So she got facial lesions where it's hard because she actually got them around her nose. So it's a little harder for her to breathe as a bulldog. So I would, if I was going to biopsy this, that'd be a great sample because you don't really have pustules, it doesn't look like from this lesion, this location, I'm sorry. So you'd get these beautiful crusts. So you just take a sample right there. And this one you probably wouldn't even need sedation for. Lidocaine that, give it 5 minutes to wait, especially if it's a nice dog. He looks a little dumpy, so he probably would let you do it. Kitty cats. Kitty cats do a little bit differently. They don't have to be this moist, but they can be. They like their ears. Cats like their ears. See, this is also a periauricular area. You're gonna have that there too. And then if you look, there's also a lesion on the nose. You can't see it great on the sample, or this picture, I'm sorry. There is a lesion on the nose also. Paronychia. This is what I mean by paronychia, where you have the crusting around the paw pad. I'm sorry, nail fold, not the paw pad. So, and it might just be a moist where you pull back the nail, extend the nail. You just have like a green crust to moist exudate, but it could also just be this crusting here. These are harder because if you only have that lesion, how do you biopsy that? You can, I don't usually. I usually do cytology, which we'll talk about, and then I treat suspectedly, supportively for that. In most cases do respond to therapy. So diagnosis, gently remove those crusts that we showed you, kind of where I would take a biopsy and kind of pat underneath it, trying not to be too aggressive because you don't want to rupture your neutrophils. If you can, if you have pustules, take a 25 gauge needle. You won't see them in cats that often. Take a 25 gauge needle, rupture it really gently, do a little pat with your cytology slide. Then you'll see degenerate neutrophils, lymphocytic cells, which I'm going to show you. And you can oftentimes get secondary bacteria. That is not uncommon at all. I'm not going to show a lot of pictures, except for in my case discussions of biopsies, because you don't really see biopsies, you see cytology. So I'll have more pictures of cytology. The lymphocytic cells you'll see, they're usually superficial with Pemphigus foliaceus. And then it's also a very neutrophilic, but also lymphocytic infiltrate. So this is going to be at 10x. You can see these are going to be all these non-degenerate neutrophils. See how happy they look? Little happy neutrophils. They're tiny because they're not that zoomed in, but there's not a lot of nuclear streaming. They're not really hypersegmented. They're kind of happy. And then you've got these big cells. Don't mistake them for just macrophages. They're so much bigger than a macrophage. Histiocyte, whatever you want to call them. Same cell. Sometimes they're really dark. Sometimes they're lighter. These are the size of a keratinocyte because they are a keratinocyte. They just don't have friends. They're all by themselves. You'll sometimes get rafts of them. That just means you'll have like 3 or 4 in a row of them. And that just means that they've lost their adhesions together. It doesn't mean they're not acantholytic cells. There still are. There are several other processes other than pemphigus that will have acantholytic cells, but not usually as many. So if I saw the sample and it looked like pemphigus, it's probably pemphigus. I'm still going to biopsy, but you probably start treatment after biopsy. As far as other diseases, dermatophytosis or ringworm and pyoderma with staph, a staphylococcal infection, they can also cause paralysis, which degrades the desmosomes and cause it, but you usually don't get the same level or same amount of the acantholytic cells. Higher power, so this is a 4x, or I'm sorry, 40x. And it might even actually be going under oil now. This one, the sample was taken a little bit more aggressively, so you've got some more nuclear streaming from the neutrophils. Let's see how big these cells are, and this is in a raft, so you've got a couple together. But these are still acantholytic cells. So treatment. Steroids are usually treatment of choice. I usually start with these guys on steroids. 50% of patients will do well with steroids alone. If you have a really severe case, you might want to do adjunctive therapy. But for dogs, I usually will start with pred. Sometimes prednisolone, depending on the size of the dog and what, I don't know what I feel that day. You know how that goes. I usually start with 1 to 2. In the literature, they'll sometimes say up to like 4 mg per kg. I am not that gutsy. I like them having an intact gut. I don't like to completely immune suppress them. I usually start with 1 to 2. Granted, they usually do go in remission. It's usually a little slower remission than if you get them really, really hit them hard. And then my maintenance is the same as every other drug. So my maintenance is usually like a quarter every other day, which is the same as like if I had an allergy case, that's what my maintenance would be. I've seen a lot of calcinosis cutis cases, so maybe I'm a little bit more gun shy. Not necessarily in my cases, but just in general. And so I don't usually go a lot of higher dosing of that. I try to keep them. Cats, I like triamcinolone. That's kind of a, I waffle back and forth between prednisolone and triamcinolone, but lately I've been on a triamcinolone kick. Those are my doses for them, but you try to get to every 3rd day. Most cases I can get to that. Sometimes I have to go every other day. And then we have a conversation of risk versus benefit. I max out no matter what the disease process is at 40 milligrams per day of pred. So I don't care if you're an Irish Wolfhound. I don't care if you're a Great Dane that weighs 200 pounds. You're probably going to still max out at 40 milligrams per day of prednisone, just because I feel like the side effects after that get a lot worse. Other adjunctive therapies. In the literature, you're going to read more about your cell cycle type treatments. So those are going to be your azathioprine, your mycophenolate, and your chlorambucil. Biggest side effect is going to be bone marrow for all of them. And then look at liver for azathioprine, diarrhea for mycophenolate, and then GI upset for chlorambucil. That's the first 2 do not go in cats normally, so chlorambucil is more of my cat one. I monitor these guys like crazy because I have killed livers with these drugs, and maybe that makes me a little bit gun shy. I'm not gonna lie. I think we all practice on what works best for us. And I've blown some guts with mycophenolate, so I monitor them really, really closely. And then once they are maintained after 3 months, then I can usually back down. If they get through the first 3 months, they're gonna be usually fine. It's just the first 3 months. So if you read the literature for Pemphigus foliaceus and are taught, atopica shouldn't really be a standard of 2nd line. I've had really good success, and that's actually what I've been going to lately, especially now that we have a pandemic and monitoring blood's a little bit more difficult. Like I just started a case of Pemphigus with my bulldog on atopica, even with doing telemedicine, because it's the best option with the safest option for them. So these are my dosing. I like I said, have really good success with it. I prefer a topical brand if I can do it. And then if I get remission, then I'll either switch over to adding in the ketoconazole, or I'll go to generic. But most of my cases are actually on the brand name. They had a really great rebate until January, which made it not so expensive. But now that's my anyway. Apologize for the books. Pregnancy's the last. All right, so now we're going to talk about the disease that everyone thinks that their dogs have and no one actually has. So I have a lot of patients, not a lot, but a substantial amount of patients that'll have like mucous membrane lesions, and they all think that they have Pemphigus vulgaris based on just reading about them. This is really rare. I can't remember the last case I've seen. So that's why I'm mentioning it, is because you really don't see it that much. And so it really should not be a common diagnosis. If you have severe lesions, mucous membranes, yes. Usually most of my mucous membrane lesions are mucocutaneous pyoderma. That's just usually what I see. I do cytology, do with antibiotics, antifungals, whichever they have based on cytology, and they do fantastic. This can kill them, this disease. So it's really, really important to make sure we have the right diagnosis, because this is a much lower prognosis than the other diseases. These cases feel like schmuck. Like they are feeling like crap. They're lethargic, they're febrile, they don't want to eat because they've got lesions in their mouth. They can actually tear at their pressure points, like think of their elbows and their hips. They can actually the skin can just tear. Lesions can definitely become generalized. They have what's called a positive Nikolsky sign. What that is you lose your adhesion between your basement membrane and your epidermis. So you can actually slide your skin, so you can do this. You'll actually feel your top layer, your epidermis, slide against your dermis. It's weird, and you shouldn't have that unless you have Pemphigus vulgaris. There are some other zebra diseases like bull's pemphigoid that can do similar things, but in general, you don't want that. This is a little Maltese that has Pemphigus vulgaris. You can see around the mucous membranes how thick, how deep those lesions are, how they look different than a foliaceus dog. You can also see the perinasal and perioral lesions too. So you have oral lesions with these, so you can see the ulcerations in the oral cavity. These guys usually feel pretty sick. They don't want to eat very well. I mean, why would you if you had oral ulcerations? You know? Cytology, you might find your cantholitic cells, not always. It's a really deep lesion. You've already lost that crust, because usually it's lost really, really easy and really superficial. You don't have pustules with this. And then also you'll have some neutrophils potentially, but it's always an inflammatory process. It might be fixed. If you biopsy, you're going to try to get around the periphery of the lesion where you have the outside ledge. So if this is your ulceration, you want to get like right here. The tombstone appearance is you still have your basement membrane, and you still have one or two cells attached to the basement membrane, because the desmosomes are higher. It's not the desmosomes, it's actually desmosomes between the skin layers. So you will have like one or two cell layers. So you get kind of this like tombstone appearance where you'll have just like one or two cells kind of coming up on that basement membrane. Again, it's more of a pathology thing. They should report that to you. These guys, I usually will try to do imaging on them, because they can have perineoplastic pemphigus, or it's very similar, where you can have the mucous membrane lesions and the oral lesions. And that obviously carries an even worse prognosis, because it means it's caused by cancer. And so you want to try to find your cancer. If you have a cancer that can be curable, like resectable, you can get complete remission with perineoplastic pemphigus. Like it's a thymoma or something like that. You can actually resect it and go back to having a normal healthy dog. Treatment. You're going to start treatment on these guys super, super fast, because these guys, they feel crummy. They're super sick. So high dose pred, usually 2 to 4 mg per kg. These guys I would consider IVIG. I consider them in really severe Pemphigus foliaceus cases too. It's a transfusion of immunoglobulins, and so it's expensive. That's all I can say about it, really. It's expensive. I've done them, not always for Pemphigus, more so for other disease processes. It's a hospitalization thing. We treat them like it's a blood product, so we treat them like if you're getting a packed red blood cell transfusion. So we monitor them really closely. The drug is expensive. It's not the easiest to get. It's a human product. So either we'll get it from a human hospital. We have it sometimes in stock, depending on, right now it's on back order, so we have some in stock. I'll also use it for like severe IMHA dogs, stuff like that. But it's not something that I usually jump to right away or really soon, unless it's a really severe case. These would be ones that if you wanted to refer, it wouldn't be a bad idea. They're just really sick. They need hospitalization, they need supportive care. Putting them on pred to go home isn't usually a fantastic idea. And then we've got kind of the hybrid. So Pemphigus erythematosus. It is a hybrid between Pemphigus foliaceus and Discoid lupus erythematosus. It only affects the nose. It doesn't go anywhere else, just affects the nose. And you'll kind of have a little bit of lesions of both. So you'll have the crusting of the Pemphigus and the depigmentation and the loss of the architecture that you'll see with lupus. So you'll kind of have, it'll be right here on here, it'll go down and it'll go up instead of just being up or down. And you, again, you don't get pop head lesions, you don't get other lesions, it's just the nose. Usually bloods are normal, so you don't have to worry about that too much. And it only stays in the nose again. So this is a kind of a classic case where you've got your crusting from your Pemphigus here, but then you're also starting to get some of that depigmentation down here. They can also not look so perfectly straight here. They can actually just go into the nose, the nasal planum too. So know that it doesn't have to just stop right there like this case is. Same story, cytology, looks like Pemphigus, because lupus doesn't really have their own cells like Pemphigus does. Biopsy, that's where you're going to get your diagnosis, and it's going to look like both. So you're going to see the hemolytic cells from the Pemphigus. You're going to see what are called apoptotic cells, where they're like a pre-programmed cell death. They're kind of bright red. I'll show you later on in the lecture. And they're going to be at the basement membrane because it's a hemidesmosome that's being affected. And you're going to have what's called an interface dermatitis. That's where you've got the epidermis, the dermis, and normally you have a really clear, distinct differentiation between the two. And there's inflammation that just kind of covers that. So you don't have that anymore. You have an interface dermatitis. Tacrolimus can be great. Otherwise, you can treat it like you would any other Pemphigus. But tacrolimus is usually nice because it's only a localized disease. So now we're going to move on to lupus. You guys probably also have all seen a DLE case, Discoid lupus erythematosus. So what this is and how it's different is, remember how Pemphigus is an IgG? This is not. It's an antibody-antigen complex disease. So you're actually going to have those develop down to desmosomes, and you have an inflammatory process because of that complex deposition. You have deeper lesions. They're going to scar. That's why you get kind of loss of the cobblestone, because you're losing your normal architecture. Doesn't mean that you're not going to like have a normal skin barrier, but it's just not going to look the same when you heal from those lesions. And again, you're going to have that lichenoid interface dermatitis, which is where you have the kind of smudging between the epidermis and the dermis on your biopsy samples. So here, it's going to, instead of being a well-demarcated line between dermis and epidermis, it's going to be an inflammatory process. You're going to have neutrophils and lymphocytes come in, and then you're going to have that kind of smudging where you're not going to see a well-demarcated line. With DLE, the biggest thing is you're going to see usually straight up just nasal planum depigmentation, loss of that cobblestone. So it looks different than most diseases. It's not just like a crusting lesion. You can have absolute crusting. You can occasionally have bleeding too, depending on, because it's a deeper lesion, depending on where it's located. Meaning if you have a capillary there, you can start to bleed. You can sometimes have it go up the nose, so you'll get kind of nasal bridge and periocular lesions. Not always, usually it stays nose, but it can go up. Primarily a disease in dogs, rarely cats. They don't generalize, and bloods are usually normal. You can have seasonality because it's photosensitive. So I oftentimes will tell owners that it can be very common to see them worsen in the summer. But even in some dogs that really love being outside in the winter, so think of your Huskies or your Arctic breeds, because then you have, not only are they outside more if they're that type of breed, so they're outside more in the winter, but then you also have the reflection from the snow, so you're getting the sunlight, and then you're getting reflection from the snow, so they're getting hit twice with sun rays, which is what's causing worsening lesion. So this is more classic DLE, where you can see really smoothing of that cobblestone appearance. You have depigmentation, you've got some erosions and crusting. This one, also you can see where it's kind of going up and going down too. So I always do cytology on these kids. And then I will treat the infection because almost all of them have infection, but I want to treat that first. And then once I make sure my infection is at least better or controlled, then I'll take a biopsy to get a diagnosis. Not everyone wants to take a biopsy of their dog's nose, so sometimes I will start treatment based on their clinical signs. So again, very common to have secondary infections, so I always treat them, especially because mucocutaneous pyoderma can look similar, and the pathologist may interpret your biopsy as a mucocutaneous pyoderma if they see bacteria, so you don't get the diagnosis. So I always try to treat first. Biopsy, kind of went over that. However, I didn't mention pigmentary incontinence. So what that means is your melanocytes, which normally carry all of your pigment cells and give you color to your skin, they lose their melanin. So they you get this kind of sheet of just straight melanin. Later on, I'll have a example of that in the cases. And then you get apoptotic cells, which are pre-programmed cell death cells. They're bright red, just only at the basement membrane. And that's important because other disease processes will have apoptotic cells, but they'll be throughout the epidermis, not just the basement membrane, and that's how you help differentiate them. So diseases like hepatocutaneous syndrome, diseases like erythema multiforme, they'll have apoptotic cells throughout the entire epidermis. I like doxyniacinamide for my treatment, especially if they're mild, they're not actively bleeding. I've got time because it takes forever to work. It takes 2 to 3 months, so I'm not expecting miracles with it. But it's a relatively safe therapy. The biggest risk is antibiotic resistance because you're using an antibiotic for a non-antibiotic reason and it's long-term. So that's a real risk, especially as a dermatologist. Like, I do worry about that. When I use them and they go into remission, I taper them together. I consider them a married pair. They cannot get divorced, they cannot split, they cannot have separation, they do not have joint custody of their children. They are married and they're married for life. There's salt and pepper, you pass them together if you're doing etiquette. So that means is if you have a doxycycline and niacinamide on twice daily and you want to reduce your frequency, you're going to go to them together on once daily. And if they're doing fantastic, then you go to every other day. You know, do your lowest effective frequency, doses stay the same, but frequency together. Consider them one drug, they're married. You can see increased tear production in niacinamide. Doesn't matter that much unless you have a fufu. A little white fufu, sorry if you have one. If you have a Maltese, if you have a toy poodle, those are the owners that care about the tear production, and those are the ones I usually hear about, so I always tell them first. You might see increased tear production, you might get some ocular staining. It is what it is. And then I always check liver values for doxy about 3 months in, and annually. Atopica works great for lupus. I really like it. You don't have to go super high dosing for most cases. Those are the most severe cases. Head works, but I don't usually think I need it that much either, kind of like Atopica. But if you have a severe case where it's really affecting the dog, I have one right now that I'm treating with prednisone based on biopsy, then I'll start them pretty heavy, especially if it's affecting their quality of life. Tacrolimus is nice because it's a topical and it's a localized lesion. And then sunscreen and avoid peak hours. So I usually tell my owners, don't go out between 10 and 3. Go early morning walks, late afternoon walks. Don't have your dog hang out outside. Whether they listen or not, whole another story. But you explain why. Whole another disease process. So systemic lupus erythematosus is also pretty uncommon. I don't see a lot of them. I feel like if we do see them, they usually come in through the internal medicine service or the emergency service because they feel like crap. Their derm lesions are usually not their biggest issue. We are a lot less rigid on our diagnostics as far as our criteria than are going to be internal or human medicine. So for us to get a diagnosis of SLE, have to have a positive ANA and 2 positive clinical signs. That's usually what we kind of try to aim at. So dermatologic lesions, you get deep erosions, ulcerations similar to DLE, but usually have lesions generalized. So it's not just going to be isolated to the nose. You can be painful either at your joints or your muscles. You can have glomerulonephritis, so you can get proteinuria. Your bone marrow can either be affected or you can have like IMHA, ITP, so you can have consumption issues or destruction issues. You can get oral ulcerations, actually pretty common in SLE. There are lots of changes with myasthenia gravis, so it's another possibility with adenopathy. Vasculitis is not uncommon, so we'll sometimes see vasculitis with these lesions, which we're going to talk about more in depth by its as its own disease process. Just because you have vasculitis does not mean that you have SLE. And these kids can oftentimes be febrile. So again, a positive anti-nuclear antibody test on top of 2 clinical signs is very suggestive of systemic lupus erythematosus. Cutaneous lesions, again, they're deep because remember you're affecting the basement membrane level. You can have transient blisters, but they're so transient and they're so delicate that you barely ever get a sample. Lesions are often generalized with systemic, and again, vasculitis lesions. Mucocutaneous lesions, again, those deep ulcers in the mouth, similar to what we saw with PV, Pemphigus vulgaris. Always look at the hard and soft palate. That's a large area where we'll see these lesions. They'll have huge kind of ulcerations and plaques there. So look at the in the mouth, and a lot of dogs are very mouth sensitive because they have these lesions. And they can oftentimes have malodor and don't want to eat because they feel like crumb. Again, we talked about that. Human medicine is a little bit more rigid on what their diagnosis is, or the diagnostics are, and how they test, and what their criteria include. So they usually include 4. And they've got minor and major criteria. So usually you're going to have 2 majors and 4 minors. And then it doesn't have to have a positive ANA. Not all of our dogs do either have a positive ANA, but usually they do. Treatment, hit these guys hard, hit them fast, they're sick. Depending on how much damage has been affected and which organs are affected, these guys can die. So this can be a fatal disease. I've lost 1 or 2 of these cases. I'm actually starting my residency. I had 3 cases, an SLE case and 2 epitheliotropic lymphomas within my first 2 weeks. I'm like, I was a dermatologist and I was supposed to die. But these guys can get sick real fast. So this one you will see. So I hope you never see a systemic lupus erythematosus. Like, that'd be great. The reason I put lupoid in parentheses because it's not truly lupus. We classify it as lupus because when you do histopathology, where you take P3, meaning you do like a declaw on a dog, you can see that basement membrane changes, but it's not a lupus disease. So it's not going to generalize, it's not going to do any lupus stuff, it's not going to be light sensitive. It is a different disease process, so just keep that in mind. Usually what will happen is you'll have like 1 nail loss, and then also you'll have like 3 nails losses. And at first the owners usually think it's just trauma. They're out playing and they lost a nail. Usually what they'll do is they'll become laminated, kind of like this one is, so it'll lift off. You have quick exposure, and then the dogs become painful and start licking that. This is regrowth of the nail. They don't come back. They're not going to be models for nails. So just keep that in mind, that they're never going to look normal again. My goal of treatment is not for them to have these beautiful, gorgeous, original nails. So they stop losing nails and they're not painful. They're still running and playing and being normal, happy puppy dogs. But yeah, this is a lost nail. This is one that was lost and is starting to regrow. This is a chronic nail. This is regrowth of a chronic nail. This one has not regrown back yet, and it might not, depending on how short it was cut. So usually, if you want a perfect diagnosis, you take B3. That's the only way to biopsy and get a diagnosis. I don't know the last case I've actually done that for, because it's kind of an aggressive way to get a diagnosis. So I don't do it. Usually the history is very, very classic. They're losing nails. Like, nothing else really causes losing nails unless they're treeing them off, which I'm going to talk about. So usually I go based on clinical signs, because the diagnosis is hard to reach otherwise. So it's pretty classic. I also go through when I do my exam and put pressure, hard pressure on every single nail, and watch the dog's behavior, sometimes with the muzzle, because it can be very painful, to see kind of help predict which nails are going to be lost. The more painful the nail is, the more likely that one's going to be affected in the future. Regardless of my treatment, there's already kind of a disease process going on at that nail fold bed. And so I can kind of differentiate that. I have had a few cases come to me that were diagnosed with systemic lupoid onychodystrophy based on clinical signs, and they were actually self-mutilators. Self-mutilators are dogs that either have a neurologic injury or they're crazy. I hate to say that. We don't know a reason why, but it's idiopathic. They start to chew off their feet. And usually their nails will go along with it. And so this is not a self-mutilation. So just know that usually you should see the nail loss first, and then they start to lick. Potentially bite, but usually they don't bite, they lick. or they just want nothing to do with their feet and they don't want you to look at their feet because they're painful. Just depends on the dog and their personality. But they should have nail loss first. They should not, if you put a basket muzzle on a dog and they can't get at their feet and their nails all grow back normally and you don't have any nail loss, that's not symmetric lupoid onychodystrophy. That's a self-mutilation syndrome. I see it more in Labradors than any other breed. I've had it in also in a Great Dane. That was a hard case where they had back injury and that dog would self-mutilate. So as far as treatments go, we've got doxyniacinamide for these guys, omega-3s. Usually, sometimes I can get them off all drugs, but the omega-3s. Sometimes you need a short course of pred to get them through, especially with acute loss, and then pain control, so codeine. So now we're going to go into our bumpy diseases. So these are going to be your Pyogranulatomous, granulomatous syndromes, your histiocytosis, and your panniculitis. So these are cases where they get just these dermal nodules. They're not usually clinical otherwise. They're not itchy, they're not painful. With Pyogranulatomous, granulomatous syndrome, they look pretty similar to everything else. If you do cytology, you see, oh my gosh, neutrophils and macrophages, hence the name of the disease process. You can have a respiratory component. I've seen several cases coming through medicine for sneezing or stridor, and they've biopsied and they've come back with this diagnosis, and then I medically manage them because they usually do get skin lesions. Bloods are usually normal. Patients feel good. Biopsy these. It's really important to biopsies. I know it's tempting to just start treatment, but it does change prognosis, which I'm going to talk with histiocytosis. So they're not hard to biopsy either. You don't have to get super deep, so you can just do a single punch biopsy. They're not painful, and most dogs are friendly. Not all, most, so you usually don't need sedation. Some pathologists will do special stains on your samples, so a PAS stain or acid shift, just to make sure you don't have infectious organisms. And then treatment is usually kind of similar to everything else. So doxyniacinamide, pred, or atopica, not all together, obviously. If there's mild, I've got lots of cases that are mild, I'll just do doxyniacinamide and that'll be their mainstay. And then I'll try to taper them off to a lower frequency. Usually need lifelong therapy, like all these diseases do, but I can usually get them down. Histiocytosis, there's two kind of categories. There's burners and there's non-burners. If you have Bernese Mountain Dog, I'd look at doing imaging on these cases because they can have systemic histiocytosis, and that's a much more severe disease process, and they can feel a lot sicker. Cutaneous is most other breeds, but you can have systemic with other breeds. It's just more common in Bernese Mountain Dogs. But they respond a lot better to therapy in general. They look the same as Pyogranulatomous granulomatous. So they've got multifocal nodules without hair loss, but they can be red. Treatment is actually very similar, but if you have systemic histiocytosis, which has a poor prognosis, you might have to add in a cell cycle drug like azathioprine or mycophenolate. And then last of the nodular skin diseases is sterile nodular panniculitis. So I've seen a lot of these cases. I don't feel like this is uncommon. A lot of them come in through ER because they really, really feel sick. Usually it's actually an attack on the adipose tissue, so they're deep. So usually what you'll have is you'll have a sub-Q nodule, and then they'll drain. And I see them oftentimes, people thinking that they're like a deep pyoderma, and they can very much look like a deep pyoderma. They can look like an actinomyces, nocardia, blastomycosis. They can look like all of these diseases. Do your cytology, do your biopsies, do all of that. Sometimes they need to be hospitalized. They're oftentimes febrile, lethargic, anorectic. Not always, but they can be. Some of them are just really mild. And I've had one case where it was thought to just be a cyst. It was removed, so pathology wasn't performed in that particular case. And then all along the surgical line, we had 5 different lesions develop along that line. And so then they referred to me, and we diagnosed them with sterile nodular panniculitis based on biopsy. Cytology, you get these foamy macrophages. So they're lipid laden. So the macrophages are trying to eat up the adipose tissue, right? So they're trying to eat up the fat. And so you get these kind of, they look like bubbles within the macrophages. You also want to do cytology to make sure you don't see like an obvious blasto case. And if you see blastomycosis, you have your diagnosis. It's easy-ish, not so much to treat. Or if you see like a bunch of, staph, then obviously you're going to do a culture and you're going to diagnose that and start them on antibiotics. But if you're just seeing these foamy macrophages, you're not seeing any infectious organisms, I'm going to be thinking sterile nodular panniculitis, but I'm not just going to jump to that because I don't want to immune compromise a dog that could potentially have something else going on. So I'm going to biopsy them. Have to get the adipose tissue, right? You have to get that subcu layer. So either you do a double punch where you take your punch biopsy, put it in formalin, and then take another one of the exact same location so you get a deeper sample. So you're not just in the epidermis and the dermis. You want to get down into subcu, unless you feel like when you took your sample, you got really, really deep, which is not that easy to do. So use your best judgment. Or you can just do a wedge resection. Just take a wedge of it, submit that. Tissue culture, it's a great in a perfect world. When you add in aerobic, anaerobic, and fungal, sometimes mycobac and actinomyces, you might be looking at another $600 to $1,000 in just diagnostics, just adding that in. So sometimes I use my best judgment, and if I really feel like we need it, based on the owner's ability to do everything. But I do strongly recommend it. This is the one exception where you clip and clean, but you don't submit it for histopath. So usually what I'll do is I'll do this first, take a sample, clip, clean, do everything aseptic. I'm putting on sterile gloves, I'm doing the whole 9 yards, and then I'm taking my histopathology sample. So I'll do my culture first, and then I'll do my pathology. Treatment, mild cases get doxyniacinamide, they do really well. More severe cases get preditopica. Sometimes my azathioprine, mycophenolate, but I don't have to use those very often. I feel like they do pretty well on prednisone and topica. The babies get juvenile cellulitis. You've probably seen a case, it's not that uncommon. I get the severe ones that try to die. I have had patients die from this. I know they shouldn't. I had one go septic, didn't respond, it was on immunosuppressive drugs. But they're pretty classic. I still biopsy them because you never want an immunosuppressive baby if you can avoid it. So they get facial swelling, big lymph nodes, they get alopecia. Make sure you rule out dermatologist and deep pyoderma because those can also cause similar signs, especially in young dogs. And they can also get nodules and drainage tracts. I have one recently that was a little bit older, and I think her biopsy didn't come back as classic. I'm pretty sure that had both juvenile cellulitis and nodular panniculitis because just the generalization of all lesions. That dog did decide to try to want to die, but didn't. She's or at least doing fantastic. So this is a picture of a little Cavalier Charles Spaniel with juvenile cellulitis. Pretty classic. But again, I would be scraping the crumb out of this little face, these little A's, because I want to make sure I'm not getting a Demodex, because obviously that's a different diagnosis and treatment. Because prednisone and Demodex don't really play well together. A little golden retriever baby. You can see the big lymph node right here. This is also called puppy strangles. So if you're hearing that name, that's the same thing. So juvenile cellulitis, we're all taught, is only a baby disease. There is a condition called adult onset juvenile cellulitis, which is completely ironic, I know. And I see it more and more now. I don't know why it's becoming more common, but I'm seeing it, and it's not an exception. Like I'll see cases coming through ER with these big obvious lesions, and I'm like, you're adult onset juvenile cellulitis. And the ER team looks at me like I have 4 heads, and I'm like, I'm guessing you're gonna be a juvenile cellulitis. And I have a 9-year-old dog that has it, and I have 2-year-old dogs that have it. So it's not super uncommon. The harder thing with adult onset is they're harder to treat. Sometimes they need longer term medications, and they need more supportive care in the beginning. So they're not quite as easy as just give them some pred and they go away and you just taper and you're good. These guys might need the atopic and the pred a little bit more long term. You might have more relapses with them. I biopsy these guys whenever I can, just because I want to make sure that I'm treating them appropriately, because if you're going to give a baby pred, you want to know why. Cytology, want to rule out deep pyoderma and Demodex, like I mentioned. I apologize. And I mentioned like atopica. Some severe cases, I've had a handful of them. Probably about 4 to 5 actually need hospitalization for a couple days for supportive care. Vasculitis. You probably all seen vasculitis. It's not that uncommon. It's just inflammation on the blood vessels that make it more torturous. The way I explain to owners, if you can imagine, your blood vessels are kind of like a big oak tree, and you've got your arteries, and they're the kind of the base of your tree, and then you have all your branches, and then they branch off, and that makes your little capillaries. And the smaller branches you get, the more tortuous those can become. And then the red blood cells are trying to make these little curves that are normally nice and gentle, but when they become tortuous and more 90-degree angles, red blood cells rupture, causing a necrotic lesion, and that's what causes your vasculitis. So I'll definitely have bleeding at the distal pinna. It's not uncommon. You can have necrosis, especially a central area necrosis that has kind of like almost like a triangular shape area where you'll lose it, so you'll have scalloping on the pinna margin. I look at tick-borne diseases, neoplasia vaccines, or idiopathic as my primary cause. You can also have vaccine-associated vasculitis. That's usually only at the location of where you gave the vaccine, but it can generalize. So if you do have it, I usually recommend trying to be very cognizant of not vaccinating if you can avoid it, or if you really have to vaccinate again, like it's a really young dog, considering pre-medicating with a steroid. But usually what those will do is they'll just get like a circular area of smoothing of the skin, kind of shiny appearance, and hyperpigmentation. It can be permanent, it can be transient, and you can get hair loss or hair regrowth. It's very dog dependent. I prepare all owners to know that that might not ever come back. And for gosh sakes, don't vaccinate in the same place because you don't have a good blood supply there. So if you're like, well, I'll just revaccinate the exact same location so they don't get another lesion. No, please don't. So the red are going to be in areas where normal vasculitis is lesions. So if you think of the areas that have those last time to get blood supply, right? Like the smallest capillaries, the very last part. So your ears are going to be the farthest away. Your feet are going to be the farthest away. Your tail tips going to be the farthest away, and your nose. Those are the areas you see it the most. And then obviously vaccine is going to be interdistal limbs, depending on which one. I see right rear the most because it's going to be raised. This is kind of what it looks like. You can see where you had a central area necrosis and you're kind of losing some of that. This one doesn't have the loss yet. This could even be something as simple as like a sarcoptic duct that's super itchy that has this too. So just be cognizant of not calling everything vasculitis if it has penile lesions. You can biopsy these. It's good to biopsies, but it's hard to get a diagnosis with these because most of the time we're getting a lesion after it's already been there. And so we don't have the inflammation around the blood vessel that is what you need for the diagnosis. So usually what we end up seeing is just some ischemic dermatopathy. So that means that you just don't have a blood supply to that area, so you get really miniaturized hair follicles, you get really thin, kind of a pale collagen appearance, really thin epidermis. Essentially, you've lost blood supply, and so you don't have a healthy skin layer. So usually with a lot of these, especially with your vaccine associated, you might just see an ischemic dermatopathy. I do blood work to make sure there's no other lesions, and a 4DX to make sure you don't have a tick-borne disease, and ultrasound to make sure you don't have like a perineoplastic process. It's not that uncommon, or not that common to have a perineoplastic. It's usually just idiopathic. Love pentoxyphylline for this drug. Dr. Whitehausen and I call it magic fairy dust. Literally, like we'll be like, why don't you add some magic fairy dust to this case? And we do. She has better, faster effect than I do. Usually for me, for my disease processes, it takes about 3 months. Ridiculously safe. The only annoyance of this particular drug is a TID drug. So you really have to give it TID for benefit, most benefit, but I will have owners give it, you know, if you're trying to do 8 hours, they might do 6 and 10 just because of their work schedule. You do the best you can, but you try. Sometimes pred, tacrolimus is a good option because if you have a localized lesion. And then no flap ear wraps are nice for those ears, so you're not having a CSI murder scene at your house. They can kind of help prevent that shaking. Kitties, we haven't talked about kitties a whole lot. So they get a condition called pillow foot, which is what people like to call it. It's actually plasma cell pododermatitis. These guys, their feet blow up, become really inflated, and then deflate. And so you have kind of this like inverted, like crinkly appearance to their paw pads, and you'll get like a white kind of crusting or fissures throughout the paw pads as over time. Usually, all you notice at first, because cats usually, most owners aren't like looking at their cat's feet. Meg, if you're watching, you're not one of those. She's my technician. So you'll have shifting leg lameness, holding the foot up, reduced activity and jumping, and then owner's like, oh wait, their foot looks weird. Yeah, their foot looks weird probably first, but you just didn't notice it because most cats don't want their feet looked at. Let's be honest, it's probably a cat thing, not an owner thing. And then you start seeing the clinical signs. only affects the feet. It usually does not generalize, but you can have other plasma cell concurrent disease processes. But this isn't the best picture because it doesn't have the white fissures, but this is how it's deflated. You can see where there's a deflation in the paw pads. It's usually not just one foot. So usually these guys generalize, they usually have multiple feet. It's not usually self-limiting, it usually progresses. You can biopsy these. Cat paw pads are not the funnest thing in the world to biopsy, I'm not gonna lie. Anytime you biopsy a cat, you need sedation because you can't do enough lidocaine to keep them comfortable, right? So usually I'll do like alfaxone and midazolam or alfaxone and torb or something like that. Or Dexmed torb if they're super safe. And then I'll put a tiny bit of lidocaine into that paw pad and take a small punch biopsy, and then you have to wrap them because usually they're gonna tear out that suture line pretty fast. I use Doxy for these guys and they do really, really well. I compound it usually because I want a liquid form. So I usually will get it, I use mixed pharmacy because it's convenient. And then you want to taper to lowest effective frequency. Cats don't really get nice in mites, so it's just a Doxy. And I use liquid because I don't want to have esophageal stricture that you can see with tablets. My goal for these is not to get normal paw pads. It's kind of like when you're dealing with a dog with SLO, Symmetric lupoid onychodystrophy. I just want them to be comfortable. So I'm monitoring more for systemic signs versus clinical signs, I guess is a better word. I don't want them being painful. I want them jumping and active and keeping their feet on the ground when they're walking. And I don't really care about the deflated appearance. So I don't really look at clinical signs as far as what it looks like. I want to look at what the cat's doing. Erythema multiforme, last and least. It is either really, really easy to treat or really, really awful to treat. There's definitely a huge dichotomy in my experience. If it is acute onset, they just got lesions, then you're going to be looking at a cause. So then you're going to be looking at drug, a vaccine, a diet, a supplement. You stop it, 3 weeks later, you have a new dog. They're doing fantastic. You have to look back. They might need hospitalization to get through there, that time frame, because they can be really, really severe to get there. But they get better within 3 days, or 3 weeks, I'm sorry. However, you have a subset called old dog EM, or chronic OM is another one, where those guys can be challenging. And you can't always find an underlying cause. And so then they're going to be a little bit harder to treat. And we'll talk about a couple cases, time assuming. These guys can affect the mucous membranes, so they can be misdiagnosed as a different disease process. They'll oftentimes have what are called serpentinous to circular maculas to plaques. That's actually where the name originally came from, is because of how these, like in humans, these very unique different forms of an erythematosus lesion. And that's why it's called that. These guys usually don't feel great. They're usually thick, they're sloughing their skin, and I'm talking about true sloughing, not just like erosions, like they will slough like the inner pinna, potentially their face. Bloods aren't usually that remarkable, except for you might have an mature neutrophilia, a significant one, but they're not like in liver failure or anything like that. Diagnosis, you have to biopsy these guys. And they can be hyperkeratotic, so that means you get like a thick crust. You don't want that lesion. This is one of the diseases where you have apoptotic cells that you'll see with lupus. It'll be throughout the entire epidermis, so programmed cell death throughout the epidermis, not just at the level of the basal membrane. Get a good history. Make sure you know every single drug. I have a case in Seattle that had recent dental, got EM. The biopsy was either EM or hepatocutaneous. Very different disease processes, but very similar in pathology. And money was not an issue. This owner had a lot of money and loved this dog, was willing to do whatever. After about 1.5 years of medications and stopping things and trying different things, because we just assumed it was a drug-induced because of the dental and thought it was going to be one of the pre-medications for the dental. Finally figured out that they changed the diet to TD at the time of the diagnosis, at the time of the dental. I was not told that, and I didn't ask. It was my mistake. I always ask details that now. We changed the diet, and the dog finally did better. We got him tapered off on a lot of medications, so it's important. Treatment, these guys gotta get hit hard, sometimes fast. I've caused one diabetic with prednisone. So then we did IVIG on that one, and that one did gorgeous, like beautiful. Other ones, I'll have some cases, have been months upon months of trying to figure out what works for them. These might be a good one to refer earlier. I have better success if I get them earlier, because chronic OM or EM is much harder to treat than acute EM. Let's see if we have time for a little time for cases. We want to go to questions.
We have a little time for cases.
Okay. So we're to meet Molly. Molly is a German Shepherd. She is the absolute best dog ever. She has a very, very fantastic owner. She's 4 years old. She has this originally central depigmentation area, never has had a bleeding episode. It started 6 months ago, and then about a month ago, she developed a secondary lesion. They had tried doing topical steroids with Animax and Odomax, and then just straight betamethasone without any improvement. So my differentials when I look at that dog, first one's gonna be nasal arteritis. Usually a St. Bernard disease. You can have arterial pulsing bleeds where these guys just like bleed out. You can actually have them bleed out where they have to come to the emergency and get cauterized. And then you have it's usually just that central lesion. You usually don't have the peripheral lesion that Molly has. Another one is Discoid lupus erythematosus. Similar clinical signs, but they're usually not so perfectly centralized like that one, like she had initially. I have to have on my list mucocutaneous pyoderma and then a fungal infection to kind of round that up. Cytology and organisms, which is fantastic. We sedate her and do a local lidocaine to get her biopsy, and I was a wuss. I am not doing that central lesion. I'm not a surgeon. I don't want to be a surgeon. There was one that just walked in because she's lecturing next. But I did not want to cut that middle of the nose because if it's arteritis, I'm gonna have a pulsing bleed. So I did not do that. I took her peripheral lesion. It's okay to be a wuss. This is her biopsy. So this is where my biopsy pictures come in. So she had kind of all the classic signs of discoid lupus erythematosus. So you have kind of this lichenoid interface dermatitis where you get this inflammatory cascade, all these little dark blue spots. Those are neutrophils and lymphocytes. So that's your inflammatory process. You don't have a well demarcated. So see here in this, it's a nose. So you're gonna have pegs. So you see how this thickening, that's well demarcated, this is not. Then you're gonna have all of these beautiful pigmentary incontinence where you have all this melanin kind of scattered throughout, not within a melanocyte. And then if you look, these are apoptotic cells and they're all at the basement membrane. Very bottom layer. All of this up here, healthy. So we get a diagnosis of discoid lupus, erythematosus. We decided to avoid sunlight and sunscreen when she is going to be outside. We started her on doxynicinamide. She did fantastic. And she stayed on that therapy long-term with no changes. This is Zeke. Zeke actually is a case from Rescued Pets Are Wonderful. I've worked a lot with that rescue group, and they do a great workup for a lot of their cases. In May, this was actually 2 years ago, but in May, he was picked up by animal control. This is what he looked like at that time. And his owners claimed him. About half a year later, he was picked up again by animal control, did not look like this at that time. The owners did not claim him. He had his standard hold, and then ARPA took him in once he was not claimed that time. And he was rushed to us because this is what he looks like at that time. He's miserable. He's intensely pruritic. We do cytology. He's got a significant staph infection, lots of inflammation, occasional to rare canthelytic cells. I started him on Cephalexin to treat the infection first to see where that can get us. A little better a month later, but definitely not normal. So then we start to wonder what else is going on with him. This is another picture of Mr. Zeke. He's a thin dog. He is miserable. His lesions are only mildly improved. His infection's improved, but definitely not gone by any stretch of the imagination. Excuse me. He's got non-degenerate neutrophils, which with a pyoderma, you should see degenerate neutrophils, not non-degenerate. He's got a lot of eosinophils, which doesn't really make sense with the pyoderma. He's having hypersensitivity to the bacteria. And he has more canthelytic cells this time. So this is a case where we got more aggressive fast because he was a 10 out of 10 itch. So I did a culture sensitivity. He did have an MDR MRSP infection, so he was prescribed clindamycin for that. I did not wait to treat it to biopsy him. I just talked to Liz from ARPA, who's their coordinator, and was like, hey, like, it might interfere with our answer, but we need to get an answer for him sooner than later. We can't just keep doing this, and we don't want to put him on immunosuppressives for his itching because that might interfere with our biopsy. So we were a little bit more aggressive with him, a little faster than I'd like to be, but he demanded it. This is his biopsy. So this is a cleft throughout his superficial dermis, or epidermis, I apologize. So these are going to be your inflammation cells. This is going to be your canthlytic cell. This is orthokeratotic hyperkeratosis. That's really normal, kind of like a basket weave appearance. But this is all of your epidermis here, and you should have, this should be all adhered, kind of like it is here. So this is a pustule. We have a good pustule for this dog sample, and that's going to be all of your sample. If this was a crust, you wouldn't have this part. You would just have all these canthlytic cells and the inflammation on top. You wouldn't have the stratum corneum. We started him on pred. I started pretty aggressively because he was, again, pretty darn miserable, along with the clindamycin still going at that time. 2 months later, no improvement in clinical signs. His infection's gone. So kept him on the pred, added mycophenolate to his drug protocol. We did bloods every 2 weeks for 2 months. And he was actually worsening. Despite being on pred and mycophenolate, he just was not getting better. We had a perfect diagnosis. It wasn't like a concerning diagnosis. He was just progressing pretty rapidly. So we started him on, we switched from the mycophenolate, and we started him on etoposide ketoconazole. We did that to help reduce costs because he's a large breed dog for the future adopter. Our pod didn't really have a concern with the cost of therapy, but they wanted to make sure that his therapy for his future adopter would be reasonable so he could find a forever home. This is Zeke, doing better. He looks pitiful here. He's not. He's a crazy man. We were able to completely get off of the prednisone over time. It took us about 2 months to get him off the pred. He's maintaining long-term on his etoposide ketoconazole. I actually haven't seen him in 2 months. He's now, or 2 years. He's now maintaining really well his primary care and his doctor, and he has his forever home. So he's doing fantastic. He's a good little dog. As far as I know, and updates from our pod have been that he's been doing really well. He's a good boy. And it was comfortable on the etoposide, so his prey is completely resolved. This is Smokey. Smokey he's a 12-year-old domestic medium hair, gorgeous cat with lovely, fantastic owners, but they have financial concerns. So this is kind of a normal case that you would see, we all see, right? Not everybody has all the money to do all the things. And so he had actually had, in 2013, a congestive heart failure event where he went to the emergency room, he got an echo, he was diagnosed with congestive heart failure. He was started based on his clinical signs and recommendations from the cardiologist on benespiral and furosemide. And he's been, at this point, he had been asymptomatic for 7 years. Not quite, because this was last year, so 6 years. And he's stayed on that combo, so he hasn't had any respiratory signs. He's been monitored really well with his primary care. About a month ago, he started getting focal lesions. This is what his lesions look like. So this is actually a cat that had pustules, super weird. And then he had the yellow tan crusting. So you can see here, he didn't really have facial lesions. This is what his cytology looked like. So you've got all these really pretty happy neutrophils. These are canthlytic cells throughout. In that 1 month when his lesion started, they treated him with clavamox twice daily for suspected pyoderma. He did not tolerate the drug well at all. Owners weren't always able to get all the drugs in him. So he was not eating well, he was losing weight. Cytology showed still persistent bacterial infection, most likely secondary. And again, all that inflammation and the canthlytic cells. The owners declined culture and biopsy. The reason they declined the culture was for financial reasons. The reason they declined the biopsy is because we had a long conversation of, can I send your cat into, well, can I kill your cat with sedation? So we talked about alfaxone and stuff like that. And also because of cost, they declined that. They wanted to treat symptomatically. So we got really brave. We put our big girl pants on, and we did prednisone. After talking to our cardiologist, I did not do a taper for him. I did not go high. I just started him on maintenance because he was relatively okay. He wasn't miserable. And so we just started maintenance dosing. We stayed there. We didn't reduce. Cats in my world get double the doses of dogs, prednisone. So they get 0.6 mg per k, whereas a dog gets 0.3. But I'm still on every other day dosing. Watched him like a hawk. owners declined to echo. I did recommend it, of course, to see where he was with his heart status. We did do some moose because they declined the culture, and I was worried about a multi-drug resistant infection. And they also declined chlorambucil and ectopica. And he's still doing great. He is on 0.6. I think last time I heard from him a couple months ago, he's been managed with his primary care. His glucose was climbing up, so we were going to kind of monitor that and potentially switch him over to etopica. Finances did continue to not be as much of an issue. But it was still within, stress, glucose, hyperglycemia. Rico, this is going to be my longest case. Rico is a sad case, so there's a lot of pictures of Rico. If you have, again, somebody that's very sensitive to pictures and sad cases, now would be the time to step away and get a snack and not watch at the same time as eating the snack. Rico's 4. He was adopted from a kind of like a rescue / shelter, not in this state. So we shouldn't know about him. Like, it's not like I'm not bad mouthing anybody. His histopath that they did through the adoption facility or his previous owner, we don't really know. We just had the sheet that said what it was. Showed pretty much lupus. Had perfect lupus diagnosis kind of criteria. They had started him on prednisone and mg/kg. And since adoption, his lesions had continued to progress. So I saw him within 2 weeks of him becoming adopted by Mary. Mary's fantastic. She's the owner. But Rico and the housemate Lily were not such friendly, and they were fighting like cats, like dogs. Not really cats and dogs, because they're both dogs. And so he was actually returned to the adoption facility for 5 weeks so she could work on behavior modification and while she was traveling. And then she was going to take him back again after that. So saw me, but was going to go back to the facility with all the medication recommendations. So this is a time adoption. And then, because I had a picture of him, she knew that she was getting a medical case. And then 2 weeks after adoption, he was still progressing. So when I saw him, he only had facial lesions. He had a diagnosis of pretty much DLE. And then we did cytology. He had a severe infection, but he had no skin barrier. Of course he did. We cultured him. Nothing was sensitive to the same. So we had 2 bugs. We couldn't use just one antibiotic. So I'm like, hey, he's DLE. I'm going to put him on doxy anyway. Let's just go higher. And I added Cefpo. So here's his huge drug concoction. He had a nice little pharmacy. He got doxy, a little higher dose than average for DLE, niacinamide, etopica, pred, and Cefpo. And then we were doing a recheck in 6 weeks because he was going to be out of town with the rescue for 5 of them. And he progressed. He progressed poorly. He was pretty awful. And so she actually didn't wait 6 weeks. She rushed. The second she picked him up, she drove to me. She actually didn't even stop at home. So we counted how much medications he should have left. They had like 40 to 60% of their medications left. They weren't giving his meds. So what we decided to do is just start his meds and see how he could do with actually getting his meds. So he did improve. He improved pretty rapidly. He's doing great. They're giving us meds. If they gave the Cefpo and etopica together, he vomited. So she just timed it out because she's awesome. Cytology, we had no bacteria. The inflammation's gone. So we plan to go 1 more week of Cefpo and stop and continue everything else. But then he relapsed, of course. The second he came off Cefpo, he got new lesions despite no bacteria. Saw him again 2 weeks later, and he has a typical cocci infection, so we still have the staph again, which the doxy should be treating. So we repeat his culture, and we didn't actually grow the staph, which is really, really frustrating because we saw it on cytology, but we didn't grow it. And it only came back as sensitive Cefpo. He didn't grade Cefpo. So we decided to put him back in Cefpo. Looking great since restarting that, getting new lesions though. So now he has lesions in his axilla, inguinal, and his dew claws. And now he's starting to get his white exit lesions that then turn erythematosus skin crust. This is his axilla. Let's see his severe lesions. Cytology is just neutrophils, no bacteria. So we decided we're going to repeat his biopsy because now he's got different lesions. So our differentials this time are drug reaction, erythema multiforme, or cutaneous lupus erythematosus. And he came back as erythema multiforme. So These are the apoptotic cells that we saw with the DLE case, but they're throughout the entire epidermis. The spongiosis is just essentially edema throughout there, and you get this huge inflammatory process. Those lymphocytes and neutrophils hanging out. So he's EM, right? So we think EM, okay, it has to be a drug reaction. Let's stop his drugs. Maybe we're doing this to him. He was doing better. So we stop his Cefpo, we change him to dexamethasone from the prednisone, just in a weird case. I've never seen pred do anything, but you never know. Anything can do anything. And I change his diet. Maybe he's a food reaction. That didn't go well. The dexamethasone caused severe diarrhea. He had new lesions throughout his entire face and through his body. So then we have a long conversation of, at this point she is getting financially constrained, but she's still in it. So we're gonna do IVIG. So we know that the cost is going to be for him about $1,500 to $2,000. We hospitalize him. If he's gonna get better, it can be hours to up to a week. He has a mild ALP elevation. He's been on pred forever, so it's like 200, I don't care. His ALT is normal. Yeah, that didn't go well. He still continued to progress. He did not get better despite doing this therapy. And he's still on dexamethasone and not tolerating it well. So he still has these erosive and ulcerative lesions all over. He's still in the Cefpo because Lord knows he can't come off of it or he flares even worse. He's drinking normally, which is good. So then we have this huge long conversation and lots of hugging and crying because we're talking about humane euthanasia. Like, is this fair for him? We've done all these things and he's still looking awful. Or do we hit him hard? Or do we go back to atopic because he was doing better for a while on atopic? I just increase his dose. We decide, since he was a potential drug reaction and he has EM, we're going to try azathioprine, pred, and pentoxifylline. We're just going to hit him hard with all new drugs. And he did great until I killed his liver. He got azathioprine hepatotoxicity. So within 2 weeks, his ALT went from 200 to 640. His ALP went from like 1,000 to 6,000. So it didn't give me a whole lot of time to do anything. I had to stop it because I was going to kill him. And that's why we monitor. That's 2 weeks of therapy, and he didn't even have a clinical sign. He's eating like a champ, drinking like a champ. No idea. That's why you monitor. So then we decided to start him on atopica. So this is actually his long-term plan. Within a month, I got his ALT and ALP reduced. They're still a little high. They're like 150, and I think his ALP up to now is still hanging around like 600, but nothing that I'd be worried about because he's on pred, and he's on a high dose of pred. These are high doses, so we've had a very long conversation. This is not something I do lightly, but this is him. This is after about 2 or 3 years of therapy. He's been hospitalized at least once for the IVIG. He's been in the hospital lots. He hates me because I'm the one that had to do his toenail trims when his feet were trying to fall off and his ear cleanings. His harness that he wears every time comes in handy because I don't get bit with his 4 teeth. But he is happy. He's comfortable. He's doing well. So to summarize, thanks for coming during the panic, the pandemic. Thanks for being on Frontline. I'm here for consults, so feel free to email me. That's my email address. You can also call the hospital for any consults. I'm not currently seeing any new cases for a couple of reasons. One, I'm pregnant with twins. I'm trying to stay healthy, just like everyone else is trying to stay healthy. So I thank you for being on the front lines. We are available for medication refills. We're available trying to do telemedicine for rechecks and stuff like that, so we can still be available to our existing clients. And also, like I said, email me. I'm available. I'm around. So yeah. And then I'm going to switch over so that we can get some questions. You can just take the mic with you. Oh, with me?
Yep. Okay, let's get questions here. No, Dr. Johnson, lunch is not being delivered, so sorry about that. Okay, so if you want to scroll here, starting with that one.
Oh, great question for tacrolimus. So somebody had asked, Dr. Rebecca Josephs is asking, what is a suggestion for an affordable tacrolimus? Wedgwood. I get mine at Wedgwood because Protopic, which is the brand name, is about $300 for a small tube. So I usually will get 0.015% or 0.0, you can't do 0.1 because that's what the brand is, but I usually will do 0.015, and I get it compounded through Wedgwood. They did have they did the merge with Diamondback. It was a pain in the bum because they lost so many prescriptions, but things have definitely gotten better. And so I'll prescribe it through them, and it's like $70 for a tube. So not super inexpensive, but definitely not nearly what Protopic is. So Dr. or Angela Urban's asking, general advice for collecting sample for culture at time of biopsy, same lesion, different lesion, other advice. Different lesion. So if you have only one, pick which one you want to do. So if you're doing a tissue culture, you'll want to do a different location because you want to clip and clean. You'll want to cut off the epidermis, so you're not going to be able to do from the same punch. If you're doing a swab culture, like you think it's more bacterial, you don't need a tissue culture, then I would just try to take a different sample because you don't want to rupture your pustule, which is what you're going to have to do for your culture, different from your biopsy. So you're going to have to take 2 different samples. If you only have one specific lesion, you're going to have to pick which one you think is more important, because really taking a swab at the biopsy site usually isn't that helpful. You can try it, but you're more likely going to get contamination because you went through the epidermis in that location. Warren Black is asking, what is doxycycline-niacinamide mode of action? And Pemphigus foliaceus is ketone. So let me ask the first one. What's the mode of action for doxycycline-niacinamide? The thought is it reduces your antibody production. So with your disease processes that are going to be antigen-antibody complexes, so obviously not Pemphigus, more your lupus, you're going to reduce your antibody-antigen complex or your production. And so that's how that's supposed to kind of work out. It's a little bit of voodoo, not gonna lie, but that's that basis behind it. In Pemphigus foliaceus, is ketoconazole for antifungal treatment, or does it have an immunologic effect? No, the ketoconazole is only for atopica. So you only use it when you're using it for atopica dosing. So what happens with atopica is it's excreted by the P450 system in the liver, and ketoconazole reduces that. So by doing ketoconazole with atopica, you can reduce your dose of atopica by 50% by adding in ketoconazole. And that's the only reason that we're doing the ketoconazole, is to reduce the cost of atopica. You do have more risk for side effects with that, both upset stomach, liver toxicity, and potentially increased dose or absorption of your atopica. So you might get a higher dose of atopica than what you really want. So you might get more side effects like the gingival hyperplasia. But really it's being used to reduce cost of therapy because ketoconazole historically is cheaper than atopica. Christine Vogel asks, do you have any great tips, or I'm sorry, tricks to prevent the dogs from licking topical meds off the nose? Yes and no. So usually the first thing I recommend is a frozen Kong. So I'll usually recommend like some peanut butter frozen, and then put the topical on, give the Kong for distraction, because you only really need 20 minutes of contact time to kind of distract them. Another thing I've used is a basket, or not a basket muzzle, but a cloth muzzle. That's too big. So they can't really open their mouth, can't open up their mouth enough to lick. You can kind of just put your finger underneath it, and that would be the best option there. Those are the only 2 I've really had good success with. There's some people that just can't do topicals at all, but it's nice when you can, especially tacrolimus for like your Pemphigus erythematosus dogs. All right. So Warren Black asks, what dose of dexamethasone do you use? You know, I'd have to look it up. I do use it, and I use oral pretty frequently, but I usually look it up when I do it. Same with triamcinolone. I just had that dose, but I would have to pull it up. I have this really fantastic book actually written by Dr. Shayla Torres, Sandra Cook, and Plum. That's dermatology therapy, and it is awesome. Like, it is worth, I think it's like 40 or 50, maybe $70. It's that soft cover. It's amazing. It was published, I think in 2012, maybe 11, but it's awesome. I would have to look up my dosing, but my frequency is to get to every 3rd day. When I use dexamethasone, I usually will do the same dose, and change the frequency between doses. So I'll start with once a day, then go to every other day, then go to every third day. Unlike PED, where I'll do a higher dose, like a mg per kg, and then reduce down amount to half to a third. Mg per kg, sorry. Why use prednisone first most of the time as opposed to dexamethasone? One is it's just easier to get. So if my owners want to switch over to prednisone or want to get like a human prescription or want to get it from the primary, most people carry prednisone. Where not a lot of people carry dexamethasone. I carry it because I'm a dermatologist and we have other specialists that use it too. Two is, honestly, there isn't a huge difference between the drugs. And I feel like people have an easier time remembering every other day dosing than every third day dosing. And I don't want people using dexamethasone every other day. It's a 48-hour drug. That's the same as equivalent of a daily drug steroid, and I think that's not safe for them long term. So that's why I try to do more prednisone. But I don't really have a better answer than that. But I do use it. I usually will use it more for the dogs that have severe PUPD on prednisone, and I'll see that they don't always have that on prednisone or on dexamethasone. They'll have less of that mineral-corticoid effect. Or the dogs that get mean on prednisone, they might not have that on dexamethasone. They might be more less have behavior changes on it. Carrie Rodman, sorry, Carrie, not Carrie. At what point do you decide to start treatment for ear margin vasculitis? If they're bleeding, for sure. I'll start them. I always have a conversation that it can progress, and so I usually do start them earlier, but keeping in mind, by the time I get them, they're already frustrated with the disease process, so I'm almost always going to start them on pentoxifylline no matter what. Your case selection is going to be a little bit different because it might just be coming in for routine stuff, and then you might be like, oh, you've got your emergent vasculitis. So my recommendation would be if you have any active lesions, like any crusts, any lesions where it's not just like a scalloped healed edge, I'd start with pentoxifylline because honestly it's safe. It's just annoying because of the TAD dosing. But almost all of mine I start because that's why they're there. I actually have a family of non-related dogs that all have it, and it's just kind of ironic. And I've done full workups, so it's not anything 40x or anything like that. Christine Vogel asks, what mg per kg do you like for triamcinolone injection when the cat won't allow oral administration? I don't. I don't give injectable steroids unless I absolutely have to because of quality of life, and then I have to look it up. Because you can't taper the same. Most of my owners aren't going to want to do an injectable at home, and Vitalogue lasts a lot longer. I see a lot more diabetes and skin fragility syndrome, stuff like that with injectable steroids. So I personally, I would more talk to them about doing like liquid, getting flavored, maybe, so especially steroids, because they don't really have a nasty flavor to start with. I feel like we can usually get them at least a yummy flavor. I do not do transdermal steroids. I had a client try to get a transdermal steroid because they will cause curling of the pinna. And so I do not do transdermal. So I would have to look it up if I really had a push came to shove type of situation because I don't use it that way. So I'm sorry I don't have that answer for you. It would probably be the equivalent of the oral. I just try not to because of all the side effects of injectable steroids if I can avoid it. I only have a handful of cases where I've actually truly had to do injectables.